Welcome to this educational video on beta-lactam antibiotics. In this presentation, we'll explore the mechanisms of action, drug classifications, spectrum of activity, resistance patterns, clinical uses, and adverse effects of the beta-lactam antibiotic family. Beta-lactams are the largest and most widely prescribed class of antibiotics in clinical medicine, accounting for approximately 65% of all antibiotic prescriptions. This class includes penicillins, cephalosporins, carbapenems, and monobactams, all sharing a common four-membered beta-lactam ring as their core structure. Understanding the nuances of beta-lactam selection, resistance patterns, and cross-reactivity is essential for every clinician, particularly given the rising global challenge of antimicrobial resistance. Let's dive into the pharmacology and clinical decision-making that guides beta-lactam therapy. Before we begin, I want to emphasize that this video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Always refer to current clinical guidelines, including the IDSA guidance documents and institutional antibiograms, when making antibiotic treatment decisions in your clinical practice. Let's start with the mechanism of action. All beta-lactam antibiotics work by inhibiting bacterial cell wall synthesis. Specifically, they bind to penicillin-binding proteins, or PBPs, which are transpeptidase enzymes responsible for cross-linking peptidoglycan chains in the bacterial cell wall. When beta-lactams bind to PBPs, they prevent the final cross-linking step, weakening the cell wall structure. This also triggers autolysins, which are the bacterium's own cell wall remodeling enzymes, leading to cell lysis and death. This is why beta-lactams are classified as bactericidal agents. Importantly, PBPs are unique to bacteria and have no mammalian counterpart, which explains the selective toxicity of this drug class. A critical pharmacokinetic principle is that beta-lactams exhibit time-dependent killing. This means their clinical efficacy correlates with the proportion of the dosing interval during which drug levels remain above the minimum inhibitory concentration, or minimum inhibitory concentration. This is fundamentally different from concentration-dependent killers like aminoglycosides. This pharmacodynamic property is the rationale behind extended and continuous infusion strategies for beta-lactams, particularly in critically ill patients, as endorsed by the 2024 International Consensus Recommendations. Remember, for beta-lactams, it's time above minimum inhibitory concentration that matters most. Now let's discuss the penicillin subclasses. Natural penicillins, such as penicillin G given intravenously and penicillin V given orally, are active against non-beta-lactamase producing gram-positive bacteria, anaerobes, and some gram-negative cocci. Penicillin G remains the drug of choice for streptococcal infections, pneumococcal/pneumococcal/ and meningococcal meningitis, enterococcal endocarditis, and syphilis. The antistaphylococcal penicillins, including nafcillin, oxacillin, and dicloxacillin, are specifically engineered to resist the staphylococcal beta-lactamase, making them first line for methicillin-susceptible Staphylococcus aureus, or MRSA, infections. Aminopenicillins, such as ampicillin and amoxicillin, extend coverage beyond natural penicillins to include gram-negative organisms like Haemophilus influenzae, Escherichia coli, Proteus mirabilis, Salmonella, and Shigella. Ampicillin is commonly used for meningitis and enterococcal infections, while amoxicillin is widely prescribed for otitis media, respiratory tract infections, and urinary tract infections. The antipseudomonal penicillins, most notably piperacillin combined with tazobactam, provide the broadest gram-negative coverage among the penicillins, including Pseudomonas/Pseudomons/aeruginosa. One important caveat: all penicillins generally offer adequate anaerobic coverage except against bacteroid species, which commonly produce beta-lactamases and are generally resistant. The cephalosporins are organized into 5 generations, with each generation exhibiting a progressively different spectrum of activity. First-generation agents like cefazolin and cephalexin have strong gram-positive activity, particularly against MRSA and streptococci, plus limited gram-negative coverage including E. coli, Proteus mirabilis, and Klebsiella pneumoniae. Cefazolin is the standard agent for surgical prophylaxis. Second-generation agents, including cefuroxime and the cephamycins cefoxitin and cefotitin, add activity against Haemophilus influenzae and Moraxella catarrhalis, with cefoxitin and cefotitin providing enhanced anaerobic coverage. Third-generation cephalosporins, such as ceftriaxone and ceftazidime, have greater gram-negative potency but reduce gram-positive activity. Ceftriaxone penetrates the cerebrospinal fluid and is used for meningitis, gonorrhea, and later-stage Lyme disease. A critical USMLE fact: ceftazidime is the only third-generation cephalosporin with antispeudomonal activity, but it lacks gram-positive coverage. Fourth-generation cefepime offers broad coverage against both gram-negative bacilli including Pseudomonas/Pseudomons/ and gram-positive cocci. Fifth-generation Ceftaroline is unique among all beta-lactams for its activity against MRSA, achieved through its affinity for the PBP2A protein that confers methicillin resistance. Carbapenems represent the broadest spectrum beta-lactams available. This group includes imipenem, meropenem, doropenem, and ertapenem. All carbapenems have potent activity against gram-positive cocci, gram-negative bacilli, and anaerobes, and they offer the most reliable coverage against bacteria that produce extended-spectrum beta-lactamase, known as ESBL-producing organisms. However, none of the carbapenems are active against MRSA. Ertapenem is the only carbapenem that lacks activity against Pseudomonas/Pseudomons/Aeruginosa and Acinetobacter, but it has the advantage of once-daily dosing, making it useful for outpatient parenteral antibiotic therapy for non-pseudomonal ESBL infections. Imipenem has activity against penicillin-susceptible Enterococcus faecalis, but not Ephesium. An important drug interaction to remember: carbapenems decrease valproate concentrations, which can precipitate seizures in patients on valproic acid. Aztreonam is the sole monobactam in clinical use. Its activity is limited exclusively to gram-negative bacteria, including Pseudomonas/Pseudomons/ and most Enterobacteriales. The most crucial clinical pearl about Aztreonam: it is the only beta-lactam with absolutely no cross-reactivity with the penicillin group, making it the safest beta-lactam option for patients with severe penicillin allergies, including anaphylaxis. Additionally, Aztreonam combined with avibactam has emerged as a treatment option for infections caused by metallo-beta-lactamase producers like NDM. The rising prevalence of beta-lactamase-producing bacteria has led to the development of beta-lactamase inhibitor combinations, which are increasingly important in clinical practice. Classic inhibitors include clavulinate, sulbactam, and tazobactam, which are paired with amoxicillin, ampicillin, and piperacillin, respectively. These inhibitors generally have little antibacterial activity of their own, with the notable exception of sulbactam, which has intrinsic activity against Acinetobacter baumannii. Piperacillin-tazobactam is a workhorse agent used for nosocomial/enscomal/pneumonia/pneumonia/febrile neutropenia and intra-abdominal infections. Newer inhibitors represent a major therapeutic advance against resistant organisms. Avibactam, paired with ceftazidime, inhibits ESBLs, AMC beta-lactamases, and KPC carbapenemases, but not metallo-beta-lactamases like NDM. Vaborbactam, paired with meropenem, and relebactam, paired with imipenem, similarly cover ESBLs, AMC, and KPC enzymes. For metallo-beta-lactamase-producing organisms, the combination of Aztreonam with avibactam is emerging as a treatment option, since Aztreonam is inherently stable against metallo-beta-lactamases, while avibactam protects against co-produced serine beta-lactamases. Understanding resistance mechanisms is critical for clinical decision-making. There are three major mechanisms of beta-lactam resistance. First, beta-lactamase production is the most common mechanism, particularly in gram-negative bacteria. These enzymes hydrolyze the beta-lactam ring, inactivating the drug. The Ambler classification divides beta-lactamases into four classes. Class A includes ESBLs, such as CTXM, TEM, and SHV variants, as well as KPC carbapenemases. Class B includes the metallo-beta-lactamases NDM, VIM, and IMP, which require zinc for activity and are not inhibited by most current beta-lactamase inhibitors. Class C includes the AmpC enzymes, which can be chromosomally encoded and inducible by certain cephalosporins, an important cause of treatment failure. And Class D includes OXA-type carbapenemases, particularly important in Acinetobacter. Second, altered PBP targets reduce drug binding affinity. The best example is MRSA, where the MECA gene encodes PBP2A, a bypass target with low beta-lactam affinity. Ceftaroline is the only beta-lactam that can bind PBP2A. Third, reduced porin channels in gram-negative bacteria decrease beta-lactam entry into the periplasmic space, often working synergistically with beta-lactamases to enhance resistance. Let's review the key clinical scenarios for beta-lactam selection. For community-acquired pneumonia/amoxicillin or ceftriaxone are standard choices. For hospital-acquired or ventilator-associated pneumonia/piperacillin-tazobactam, cefepime, or a carbapenem should be used depending on local resistance patterns and multi-drug resistant risk factors. For MSS of bacteremia and endocarditis, nafcillin or cefazolin are first line, and cefazolin is increasingly recognized for its comparable efficacy and better tolerability. For bacterial meningitis due to Streptococcus pneumoniae and Neisseria meningitidis, ceftriaxone is the cornerstone of empiric therapy, often combined with vancomycin for resistant pneumococci. For intra-abdominal infections, piperacillin-tazobactam or a carbapenem provides excellent anaerobic and gram-negative coverage. For febrile neutropenia, cefepime, piperacillin-tazobactam, or meropenem are standard empiric regimens. For infections caused by KPC producing carbapenem-resistant Enterobacterales, the IDSA 2024 guidance recommends ceftazidime-avibactam as a first-line agent. And for patients with severe penicillin allergy, Astrienam is the go-to beta-lactam alternative. Beta-lactams are generally well tolerated, but several adverse effects deserve your attention. Hypersensitivity reactions are the most common adverse effect and range from mild rash to life-threatening anaphylaxis, though true anaphylaxis occurs in only 0.05% of cases. Gastrointestinal side effects, particularly diarrhea, are common with all beta-lactams, and Clostridioides difficile infection is a real concern, especially with broad-spectrum agents like third-generation cephalosporins. Neurotoxicity, including seizures, is more commonly described with imipenem and cefepime, but is likely a class effect, with risk increased in patients with renal impairment, advanced age, or history of seizures. Dose adjustment in renal failure is essential to prevent this complication. Hematologic reactions including neutropenia can occur with prolonged high-dose therapy and are generally reversible upon discontinuation. Acute interstitial nephritis is a recognized hypersensitivity-mediated adverse effect of beta-lactams that classically presents with fever, rash, eosinophilia, and rising creatinine, though this full triad is actually seen in the minority of cases. Both neutropenia and interstitial nephritis resolve with drug discontinuation. A commonly tested and clinically important topic is beta-lactam cross-reactivity. The traditional teaching of 10% cross-reactivity between penicillins and cephalosporins is outdated and has been debunked. Current evidence shows that cross-reactivity is driven by shared R1 side chains between specific agents, not the beta-lactam ring itself. Overall, the cross-reactivity rate between penicillins and unrelated cephalosporins is less than 2%. Second, third, and fourth generation cephalosporins and carbapenems display very low cross-reactivity in penicillin-allergic patients. Critically, more than 95% of patients labeled with penicillin allergy do not have a true allergy. For low-risk patients with remote histories or cutaneous-only reactions, direct oral challenge without preceding skin testing is now supported by evidence. IgE-mediated responses are thought to wane over time, and many childhood reactions were never true allergies to begin with. However, for patients with a confirmed history of severe anaphylaxis, Astrienam remains the only beta-lactam with absolutely zero cross-reactivity to penicillins. Desensitization protocols, involving a graded challenge under close monitoring, may be warranted when a specific beta-lactam is essential and no suitable alternatives exist. Let's summarize the key points about beta-lactam antibiotics. The mechanism involves inhibiting cell wall synthesis by binding PBPs, with time-dependent killing pharmacodynamics. Penicillins range from narrow-spectrum penicillin G to broad-spectrum piperacillin. Cephalosporins span 5 generations, with progressively broader gram-negative coverage, and Ceftaroline uniquely covers MRSA by binding PBP2A. Carbapenems offer the broadest spectrum and are first line for ESBL infections, while Astrinam covers only gram-negatives with zero penicillin cross-reactivity. Beta-lactamase inhibitor combinations extend coverage against resistant organisms, with newer agents covering ESBLs, AmpC, and KPC enzymes. The three major resistance mechanisms are beta-lactamase production, which is the most common, altered PBPs as seen in MRSA, and reduced porin channels in gram-negatives. Key adverse effects include hypersensitivity reactions, GI disturbances including C. difficile, neurotoxicity with seizure risk, and interstitial nephritis. Cross-reactivity between penicillins and cephalosporins is less than 2%, driven by shared side chains rather than the core ring structure, and the old 10% rule is a myth. The information in this presentation is based on Harrison's Principles of Internal Medicine, 22nd edition, and peer-reviewed clinical literature including the IDSA 2024 guidance on antimicrobial-resistant gram-negative infections. All references are listed on this slide with their full citations and PubMed identifiers for your review. Thank you for watching this educational video on beta-lactam antibiotics. Remember to always consult current guidelines and local antibiograms when prescribing antibiotics for your patients.